Welcome back to Bright Life Sciences. Before we dive into today's new content, let's go through the answers to last episode's short answer questions. SHU1, a patient with chronic kidney disease takes a drug that is 90% renally excreted. What happens to the plasma drug concentration over time, and what dose adjustment is required? Well, in chronic kidney disease, GFR, which is the glomerular filtration rate, falls. And because this particular drug is 90% renally excreted, the kidneys are doing almost all the work of clearing it from the body. When the kidneys fail, clearance drops dramatically. So what happens? The drug begins to accumulate in the plasma, the half-life becomes prolonged, and this takes longer and longer to eliminate each dose of this drug. And if the dosing stays the same, the patient reaches toxic plasma concentration. The key rule here is chronic kidney disease leads to reduced renal clearance, which leads to increased half-life, which then leads to drug accumulation. So we must either reduce the dose, keeping the same interval, or extend the interval, keeping the same dose. We use creatinine clearance calculated using the Cockford-Gault equation to guide exactly how much to adjust. For gentamicin, for example, we extend the interval in chronic kidney disease to avoid the drug reaching ototoxic or nephrotoxic levels. High yield list for the exam: aminoglycoside, digoxin, metformin, lithium, vancomycin, cephalosporins, penicillins, acyclovir, and fluconazole. You can remember these drugs as a drug must live via careful, precise, active filtration, whereby A goes for aminoglycosides, drug for digoxin, must with metformin, live with lithium, via with vancomycin, careful with cephalosporins, precise with penicillins, active filtration for acyclovir and fluconazole. For our SHU2, short answer question 2, which was about grapefruit and simvastatin. Why should grapefruit juice not be taken with simvastatin? What pharmacokinetic mechanism is involved? And what is the clinical consequence? Well, grapefruit contains compounds called furanocoumarins, especially bergamotin being the classic example, which irreversibly inhibits CYP3A4 enzymes in the gut wall. Notice the word irreversibly. This is important. Even just one glass of grapefruit juice can inhibit CYP3A4 for 24 to 72 hours. Simvastatin is a CYP3A4 substrate, meaning it depends on the enzyme for its first-pass metabolism. When CYP3A4 is blocked, simvastatin bypasses that metabolism, and its bioavailability can rise up to 15-fold. At 15 times the normal plasma level, you get rhabdomyolysis, which is the breakdown of muscle tissues and a serious risk of acute kidney injury. This is a pharmacokinetic drug-food interaction at the absorption and metabolism phase. Other drugs in the same boat include cyclosporin, felodipine, midazolam, amiodarone, and tacrolimus. All of these are CYP3A4 substrates. The FDA now requires grapefruit warnings on their labels. The clinical bottom line here is there is no safe time window. Patients on these drugs should avoid grapefruit entirely. SHU3. Explain enterohepatic saturation. Name 2 drugs and explain why this extends their half-life. Enterohepatic saturation is a recycling loop for drugs. Here is how it works. After oral absorption, the drug is metabolized in the liver and excreted into bile as a water-soluble conjugate, usually a glucuronide. That conjugate travels into the small intestine. In the gut, bacteria produce an enzyme called beta-glucuronidase. This enzyme strips off the conjugate, regenerating the active free form of the drug. That active drug is then reabsorbed back into the photosaturation, returned to the liver, and the cycle repeats. This recycling loop significantly extends the drug's effective half-life and its duration of action. Drug 1, we have morphine. Morphine 6-glucuronide is excreted in bile, deconjugated in the gut, and reabsorbed as active morphine. This is why morphine's analgesic effect can outlast what you'd predict purely from its plasma half-life. Drug 2, we have ethinyl estradiol, the estrogen in the oral contraceptive pill. It undergoes the same cycle, When antibiotics like ampicillin are given, they kill the gut bacteria that perform deconjugation. Less active drug is reabsorbed, estrogen levels drop, and contraceptive efficacy can be reduced, a crucial clinical power. Other drugs with intrahepatic saturation include chloramphenicol, doxycycline, rifampicin, indomethacin, and estrogen as a class. And now the long answer question. The pharmacokinetic basis of drug-to-drug interactions, we have enzyme induction, inhibition, protein binding displacement, and renal competition. Mechanism 1, enzyme induction. An inducer increases CYP enzyme synthesis. This speeds up the metabolism of co-administered drugs, which lowers their plasma levels and reduces their effect. The onset is slow, days to weeks, because new enzyme protein must be synthesized, and the offset is equally slow for the same reason. Classic examples in this case we have rifampicin, which induces CYP3A4, reducing oral contraceptive levels, leading to contraceptive failure. Phenytoin reduces warfarin's anticoagulant effect. Phenobarbital reduces corticosteroid efficacy. Mechanism 2, enzyme inhibition. An inhibitor blocks CYP enzyme activity. This slows the metabolism of substrate drugs, raising plasma levels leading to enhanced effects or toxicity. Onset is rapid and offset is equally rapid. Examples, we have ketoconazole with tafenadine. They cause photocardiac arrhythmias. These interactions actually led to tafenadine being withdrawn. Cimetidine inhibits CYP and raises warfarin and diazepam levels. Grapefruit, as we just discussed, inhibits CYP3A4 and raises simvastatin levels. Mechanism 3, protein binding displacement. Drug A displaces drug B from albumin, suddenly increasing the free active fraction of the drug B. This transiently increases the effect and toxicity of drug B. However, the effect is usually short-lived because the higher free levels also trigger more metabolism and excretion. Classic example, we have aspirin displaces warfarin from albumin, transiently increasing the risk of bleeding. Sulfonamides displaces bilirubin from albumin in neonates, causing kernicterus. High protein binding drugs to remember, we have warfarin at 99%, diazepam at 97%. Mechanism 4, we have renal competition at tubular secretion. Two drugs compete for the same renal tubular transporter. OAT for organic anions, OCT for organic cations. One drug blocks the other's excretion, raising its plasma level. The classic example here is actually a beneficial interaction. Probenecid blocks OAT, reducing penicillin excretion and raising its plasma level. This was deliberately used during World War II when penicillin was scarce to extend its duration of action. Probenecid also increases uric acid excretion, so it's used in gout treatment. A patient on digoxin gets the normal dose but ends up toxic. Why? Because nobody calculated the right maintenance dose for her kidney function. On the left, a normal patient, she takes 0.25 milligrams of digoxin per day. Her kidneys excrete it normally. Her half-life is 36 to 48 hours. Her plasma levels stay therapeutic. On the right, a CKD patient, a chronic kidney disease patient, takes the same dose, but her renal clearance is reduced. Digoxin accumulates. The half-life extends, the plasma levels become toxic. Same drug, same dose, completely different outcome. Why? Because of pharmacokinetics. Understanding kinetics, half-life, clearance, and dosing, this saves lives. That is exactly what Pharmacokinetics Part 2 is about. Let's get into it. Welcome to Bright Life Scientists. Illuminate, educate, inspire. By the end of this episode, you'll be able to do 6 things. Distinguish zero order from first order kinetics and state the clinical implications of each. Calculate and interpret half-life and explain its clinical significance. Define clearance, hepatic, renal, and total body with the correct formula. Explain steady state, when it is reached, what determines it, and why it matters clinically. Calculate loading dose and maintenance dose using standard pharmacokinetic formula. Describe therapeutic drug monitoring, what it is, when it's indicated, and which drugs require it. These are the 6 pillars of Pharmacokinetics Part 2. everything connects. Let's begin. Zero order versus first order kinetics. Order of kinetics. The rate of drug elimination is related to plasma concentration by the equation rate equals to plasma concentration with the power of n, where n is the order. Most drugs follow first order kinetics. Very few follow zero order. Let's understand why that distinction is important. First order kinetics, also called linear kinetics. In first order kinetics, a constant fraction of the drug is eliminated per unit time. The rate of elimination is directly proportional to the plasma concentration. Double the plasma concentration, double the elimination rate. Clearance and half-life both remain constant. This makes first order drugs predictable and safe to dose. Most drugs, including penicillin, paracetamol, morphine, warfarin, follow this first order kinetics. On a log linear plot, you get a straight line. Zero order kinetics is nonlinear. In zero order kinetics, a constant amount is eliminated per unit time. In first order, we said a constant fraction of the drug is eliminated per unit time. But in zero order kinetics, a constant amount is eliminated per unit time, regardless of the concentration. The elimination pathway is saturated. The enzymes are working as fast as they can and cannot speed up. Half-life is not constant in this case. It increases as the dose increases. Clearance falls at higher concentration. This makes zero-order drugs dangerously unpredictable. The pure zero-order drugs you must know include alcohol, phenytoin at therapeutic levels, and aspirin at high doses. Critical exam point here, any drug at sufficiently high concentration when its metabolic pathway becomes saturated can switch to zero-order kinetics. Phenytoin and alcohol are the classic examples here. This is why a small dose increase in phenytoin can cause toxicity. Half-life, formula and clinical significance. Half-life is the time required to reduce the plasma drug concentration by 50%. The formula is T half equals to 0.693 multiplied by volume of distribution divided by clearance, where 0.693 is the natural log of 2. This is a secondary parameter. It does not exist in isolation. It is derived from two primary parameters, volume of distribution and clearance. If volume of distribution increases, half-life increases. If clearance decreases, as in kidney or liver disease, half-life increases. Always trace half-life changes back to VD and clearance. Now, the clinical significance, half-life determines the dosing interval. Short half-life drugs need more frequent dosing. Penicillin every 6 hours. Long half-life drugs can be dosed once daily or less. Amiodarone every few weeks. Half-life determines the time to reach the steady state. It always takes 4 to 5 half-lives. Regardless of the dose, this is one of the most important rules in pharmacokinetics. Half-life also determines how long it takes to eliminate a drug after stopping it. Again, 4 to 5 half-lives. But here is the key distinction that trips up many students. Half-life does not determine the steady-state plasma concentration. That is determined by the dose rate. Half-life only tells you the timing. Dose rate tells you the level. Look at the elimination table. After one half-life, 50% is eliminated and 50% remaining. After 2 half-lives, 75% eliminated. After 3, 87.5 eliminated. After 4, 93.75. After 5 half-lives, 96.9% is gone. Clinically, the drug is eliminated. Clearance. Well, what is clearance? Clearance is the volume of plasma completely cleared of drug per unit time, expressed in liters per hour. The fundamental formula, clearance equals to rate of elimination divided by plasma concentration, or equivalently, clearance equals to blood flow times extraction ratio, and total body clearance equals to hepatic plus renal plus any other routes. Hepatic clearance, here the liver removes drug from blood. How effectively it does this depends on two things. Hepatic blood flow, denoted as Q, and the extraction ratio, denoted as E. High extraction drugs, those with an extraction ratio above 0.7, are cleared so efficiently that their clearance approaches the hepatic blood flow itself. Anything that reduces liver blood flow, like heart failure or cirrhosis, will dramatically reduce clearance of these drugs. Examples include morphine, propranolol, lignocaine, and others. Low extraction drugs, extraction ratio below 0.3. These are not sensitive to blood flow. Their clearance depends almost entirely on enzyme activity, the CYPs. So enzyme inducers or inhibitors have a big impact. Examples here we have warfarin and diazepam. Renal clearance, three mechanisms are involved. We have glomerular filtration of the free drug, tubular secretion via organic transporters, and tubular reabsorption, which reduces the excretion. Renal clearance falls in CKD, in the elderly with reduced GFR, and in dehydration. Alkalinizing the urine with bicarbonate ionizes weak acid drugs, trapping them in the tubule and increasing excretion. This is the basis of forced alkaline diuresis in salicylate poisoning. Total body clearance is the sum of all routes. It's used to calculate the maintenance dose. Maintenance dose equals to clearance multiplied by target concentration multiplied by the dosing interval. When clearance falls in renal or hepatic failure, the drug accumulates and the maintenance dose must be reduced. Steady state. When and why it matters. Steady state is the plasma concentration at which the rate of drug administration exactly equals the rate of elimination. On repeated dosing, drug accumulates until this equilibrium is reached. There are three separate rules governing steady state, and each depends on a different pharmacokinetic parameter. This is where many students go wrong by mixing them up. Rule 1. The time to reach steady state depends only on the half-life. It always takes 4 to 5 half-lives, regardless of the dose. A short half-life drug like amoxicillin reaches steady state within hours. A long half-life drug like amiodarone, with a half-life of 50 days, takes months to reach steady state. This is why amiodarone needs a loading dose strategy. Rule 2. The level of steady state, the actual plasma concentration, depends on the dose rate, which is dose divided by dosing interval. Double the dose rate, you double the steady state concentration. This is completely independent of half-life. To raise a patient's warfarin steady state level, you increase the daily dose. Rule 3. The variation between peak and trough at steady state, the peak-trough fluctuation depends on the dosing interval relative to the half-life. A shorter dosing interval gives a smaller fluctuation around the average steady state, but the average concentration stays the same. As long as the total dose rate is equal, so 100 milligrams every 8 hours gives the same average steady state concentration as the 300 milligram once daily, but very different peaks and troughs. Summary: the time it takes to reach the steady state concentration is set by half-life, and the level of steady state concentration is set by the dose rate. The variation at the steady state concentration is set by the dosing intervals. 3 rules, 3 parameters, learn them separately. Loading dose versus maintenance dose. Formulas. Dosing strategies. Consider digoxin. It has a half-life of 36 to 48 hours. Without a loading dose, it would take 4 to 5 half-lives, up to even 10 days, to reach a therapeutic steady state. In a patient with acute heart failure, we cannot wait 10 days. So we use a 2-dose strategy, the loading dose formula. Loading dose equals to volume of distribution multiplied by the target plasma concentration. The loading dose depends primarily on volume of distribution. A drug with a high volume of distribution is extensively distributed into tissues. So you need a large loading dose to saturate those tissues compartments and achieve a therapeutic plasma level quickly. The risk is toxicity if the loading dose is too high. You can't ungive a drug. Examples: digoxin loading dose is 1 to 1.5 milligram. Amiodarone loading dose is 200 milligrams 3 times daily for 1 week. The maintenance dose, let's talk about the maintenance dose formula. Maintenance dose equals to clearance multiplied by the target plasma concentration multiplied by the dosing interval. The maintenance dose depends primarily on clearance. It replaces exactly the amount of drug eliminated during each dosing interval. maintaining steady state. When clearance falls in renal or hepatic failure, the maintenance dose must be proportionally reduced. For digoxin in chronic kidney disease, we use GFR to calculate the dose reduction. Two-dose strategy in summary. Give a large loading dose first to achieve therapeutic levels. Immediately then switch to smaller maintenance dose to sustain those levels. Classic drugs using this strategy include digoxin, amiodarone, and heparin infusions. High yield formula summary. Loading dose equals to volume of distribution times the steady state concentration. Maintenance dose equals to clearance times steady state concentration times tau. Loading dose depends on VD, maintenance dose depends on clearance. Therapeutic Drug Monitoring, TDM. Therapeutic drug monitoring is the practice of measuring a drug's plasma concentration and using that measurement to adjust the dose, keeping the patient within the therapeutic window, above the minimum effective concentration, below the minimum toxic concentration. Therapeutic drug monitoring is not needed for every drug. It's indicated when certain conditions are met. The drug must have a narrow therapeutic index, a small gap between effective and toxic doses. There must be a known, reliable relationship between plasma level and effect. There must be significant variability between patients in their pharmacokinetics, and the drug's effect must be difficult to measure directly by other means, like a clinical endpoint. Other indications include organ failure, altering drug handling, especially renal or hepatic failure, and suspected non-compliance. The drugs requiring TDM, learn them from DIO-TV. Use DIO-TV to remember them, where D stands for digoxin, A is for aminoglycosides, lithium goes with L, antiepileptics, phenytoin and valproates, theophylline and vancomycin, cyclosporin. Know the therapeutic ranges. Digoxin, the therapeutic range is between 0.8 to 2 nanograms per liter. Gentamicin, peak 5 to 10, far below 2 micrograms per milliliters. Lithium is 0.6 to 1.2 milliequivalents per liter. Phenytoin and theophylline, both 10 to 20 micrograms per milliliter. Vancomycin TRA, 10 to 20 micrograms per milliliter. Therapeutic drug monitoring is not indicated for drugs where you can directly measure the effect. Antihypertensives, you measure blood pressure. Warfarin, you measure the INR. Antidiabetics, you measure glucose and HbA1c. And for drugs that produce active metabolites, plasma levels of the parent drug may not reflect clinical effect. Well, it's time to test yourself. Pause the video now, write down your answers, and come back when you're ready. Don't scroll ahead. Now, let's go back to the question we opened with. Why did the digoxin patient develop toxicity on a perfectly normal dose? 3 reasons, all connected by what we have learned today. First, CKD, chronic kidney disease, reduced renal clearance. Digoxin is 60 to 80% renally excreted. In chronic kidney disease, GFR falls. Clearance drops dramatically. The drug cannot leave the body at its normal rate. Second, extended half-life led to drug accumulation. Remember the formula T half equals to 0.693 times VD, which is volume of distribution divided by clearance. When clearance falls, half-life extends from 36 hours to potentially days. Each new dose arrives before the previous one has been adequately eliminated. Levels build up, toxic concentrations are reached. Third, the maintenance dose was never adjusted. The correct approach is to use the Cockcroft-Gault equation to estimate GFR, and then reduce the maintenance dose in proportion. The formula is maintenance dose in chronic kidney disease equals to maintenance dose normal times the patient's creatinine clearance divided by normal creatinine clearance. Failing to make this calculation is the root cause of digoxin toxicity in renal patients. This is why pharmacokinetics part 2 matters. Kinetics, half-life, clearance, dosing, these 4 concepts understood together equals to patient safety. Let's reveal the MCQ answers. Question 1, the answer is C. 32 to 42 hours. Steady state takes 4 to 5 half-lives. With a half-life of 8 hours, 4 times 8 is 32, 5 times 8 is 40. This rule is absolute. It applies regardless of the dose or the drug. It is purely a function of half-life, So if a drug has a half-life of 10 days, like amiodarone, steady state takes 40 to 50 days. That's why a loading dose is essential for long half-life drugs. Question 2, the answer is B. Remains unchanged. In zero-order kinetics, a constant amount is eliminated by unit time, completely independent of plasma concentration. The elimination pathway is already saturated. It physically cannot go faster. Doubling the concentration does not double the rate. This is the dangerous unpredictability of zero-order drugs. Small dose increases cause disproportionately large rises in plasma levels. Question 3. The answer is B. Give loading dose first, then maintenance dose. This is the two-dose strategy. The loading dose calculated from VD rapidly saturates tissue compartments and achieves therapeutic plasma levels immediately. The maintenance dose calculated from clearance then sustains those levels. The classic examples, we have Digoxin and amiodarone. Remember, loading dose depends on VD and maintenance dose depends on clearance, CL. And now, the moment you've been waiting for. Fact Frog says, did you know? Fact 1. Phenytoin, the drug that breaks its own rules. Phenytoin is one of the most pharmacokinetically complex drugs in medicine. At low doses, it follows first-order kinetics, predictable. But at therapeutic doses, which are very close to toxic doses, it saturates its own metabolizing enzyme CYP2C9 and 2C19 and switches to zero-order kinetics. What does this mean in practice? A tiny dose increase produces a huge rise in plasma levels. A patient stable on 300 milligrams per day can become toxic by adding just 50 milligrams more. This is why phenytoin, therapeutic drug monitoring, and careful dose titration are absolutely essential, and why its therapeutic window is notoriously narrow, 10 to 20 micrograms per milliliter. Fact 2. Amiodarone has the longest half-life of any common drug in medicine. Its half-life is approximately 40 to 55 days. This means it takes nearly 6 months to reach steady state on a regular maintenance dose. That's why a loading dose regimen is used. 200 milligrams 3 times daily for 1 week, then twice daily for 1 week, then once daily. And the flip side, once amiodarone is stopped, its effect persists for months. It can cause thyroid, pulmonary, liver, and corneal toxicity long after discontinuation. Its massive volume of distribution, 66 liters per kilogram, means it is deeply embedded in tissues. Dialysis cannot remove it. Always monitor TFTs, thyroid function tests, LFTs, chest x-rays, and eye exams in patients on amiodarone. Time for the DLS memory trick. To remember the 6 key components of pharmacokinetics, part 2, use this mnemonic. Half-clever students survive doses. H stands for half-life. We said half-life equals to 0.693 times volume of distribution divided by clearance. Half-life determines dosing interval and time for steady state to be achieved. 4 to 5 half-lives are required to reach steady-state plasma concentration, and 4 to 5 half-lives are required to eliminate the drug. It is constant in first-order kinetics, but the half-life is variable in zero-order kinetics. C stands for clearance, whereby clearance equals to the rate of elimination divided by plasma concentration. The total clearance equals to hepatic plus renal plus other clearances. S stands for steady state. Rate in is equal to rate out. The time required to reach steady state concentration is set by half-life. Level of steady state concentration is set by dose rate. The variation at steady state concentration is set by dosing interval. The other S stands for strategy. Loading and maintenance dose differ, whereby loading dose equals to VD times target concentration, and this depends on VD. Maintenance dose equals to clearance times target concentration times TAU. It depends on clearance. Use two-dose strategy for high volume of distribution in long half-life drugs. Then D stands for dosing. We said therapeutic drug monitoring. You can remember the drugs used in this case as DIO-TV, where we have DIAL-TV. These have narrow therapeutic index drugs. You can adjust them in CKD or chronic kidney disease, liver failure, elderly. Half-clever students survive doses. Say it once more in your head. That's your entire episode in 5 letters. Take a screenshot of this slide right now. This is your revision card for Pharmacokinetics part 2. order of kinetics, we have half-life here, we have clearance, we have steady state, loading and maintenance dose, therapeutic drug monitoring, the drugs that actually are supposed to be monitored before they are administered. And don't forget to add your master mnemonic here. Have clever students survive doses, where I said H stands for half-life, clever, C stands for clearance, S for steady state, then S for strategy, whereby we have loading dose and maintenance dose, then we have D as well. Now it's your turn. Here are the short answer questions and long answer questions for episode 3. Answers will be revealed in episode 4. SHU1, SHU2, SHU3, and the long answer question. Comment your answers below. Your peers and I will be discussing them before episode 4 drops. Thanks for watching episode 3. And that is Pharmacokinetics part 2. Kinetics, half-life, clearance, and dosing done. If this episode helped you, please subscribe for episode 4. We are covering pharmacodynamics part 1, where I'll be talking about receptors and drug receptor interaction, and it is a fantastic one. Drop a bell notification so you don't miss it. Leave your SHU answers in the comments. I read every single one. And if you know a fellow medical or pharmacy student who's struggling with pharmacokinetics, share this video with them. You'll be doing them a genuine favor. Guide life scientists, illuminate, educate, inspire. See you in episode 4.